Good morning, everyone. Today, I'll be discussing a very rare and unusual presentation of Rosai-Dorfman disease of the fourth ventricle, mimicking an intraventricular tumor in a young patient. So, this is a 20-year-old young man who presented with altered sensorium, and on emergency basis, he underwent limited MRI study and was immediately taken for surgery. His MRI revealed a lobulated space-occupying lesion in the fourth ventricle that approximately measured 4.5 into 3.5 centimeters, causing moderate hydrocephalus. There was no periventricular ooze of the CSF and moderate compression over the pons and the medulla with caudal protrusion of tonsils by 10 mm, causing secondary mass effect in the posterior fossa was noted. Now, what are the possible differential diagnoses we can think of a space occupying lesion in the young? So, on imaging, it could be an ependymoma, a medulloblastoma, choroid plexus papilloma, and very remotely, you can think about a rosette forming glioneuronal tumor. The operating surgeons are Dr. S. Prabhakar and Dr. Nikhil Tadwalkar, neurosurgeons from Solapur, and these are their operative notes. Suboccipital craniotomy with telovelar approach. The tumor was avascular attached to the choroid plexus. Complete excision was done and post-operative course was uneventful. So these are the intraoperative images, and the tilovelar approach exposing well circumscribed gray white nodular lesion. Cerebellar tissue is seen at the 11 o'clock position. Brainstem was seen at the anterior aspect after total excision. We received soft yellow nodular masses in our lab. Microscopy revealed a cellular lesion composed of polymorphous population of cells. There were numerous histiocytes of varying sizes which had foamy to granular cytoplasm, and these histiocytes exhibited emporipolysis, that is engulfment of intact white blood cells. These could be lymphocytes, plasma cells, or even polymorphonuclear cells, and occasionally eosinophils. And rest of the tissue showed moderate to dense infiltration by lymphocytes and plasma cells. Even Russell bodies were noted, and there was foci of fibrosis and clustering of the blood vessels. So these are the histiocytes. You can see they have granular cytoplasm with engulfment of intact WBCs. Now, the nucleus of the histiocyte is large, vesicular with prominent nucleoli, and you can see this histiocyte, it has engulfed the neutrophil here along with the lymphocytes. So there is variable fibrosis, presence of Russell bodies here, and infiltration by lymphocytes and plasma cells. So we went ahead with immunohistochemistry, and these large histiocytes you can see are strongly positive for S100. The nuclear as well as the cytoplasmic stain is positive, and these pale cells in the center you can see these are the engulfed WPCs, that is the lymphocytes and the plasma cells. So this is S100 positivity. CD68 was also cytoplasmic positive. We went ahead, we completed the immunoprofile, and CD3 and CD20 was focally expressed in the scattered cells. The Ki67 index was very low, 1 to 2%. We did CD1A to rule out Langerhans cell histiocytosis, and BRAF P600E was negative. We did EMA to rule out meningioma and CD30 to rule out lymphoma. So we rendered a diagnosis of Rosai-Dorfman disease of the fourth ventricle. We have even published this article in the Asian Journal of Neurosurgery in May 2024. 2024. So retrospectively, a detailed history was taken. Thorough examination revealed there was no history of fever, anemia, weight loss, or any generalized lymphadenopathy. A high resolution CT and ultrasound screening of thorax, neck, abdomen, and pelvis were also normal. PET scan was repeated after 1 year. That was normal. So, coming to the history of Rosai-Dorfman disease, it was originally described by a French pathologist, Destombes, in 1965 as adenitis with lipid excess. Subsequently, it was characterized as a distinct clinical pathological disorder 4 years later, that is in 1969, by Rosai and Dorfman as sinus histiocytosis with massive lymphadenopathy. This is a benign and a self-limiting disease. The median age is 50 years. However, there is a wide range ranging from 2 to 70 years. The classic or the nodal, that is R type, has a frequency of 30 to 50%, and these patients present with enlarged lymph nodes, most commonly affecting bilateral cervical nodes in young males. It is characterized by overproduction and infiltration of the histiocytes within the lymph nodes. The extranodal involvement of RDD is also known in 30% of cases. The skin type or the C type, cutaneous type, is found almost in 50% of cases, and the other organs affected or the other tissues affected are salivary gland, thyroid, CNS, and even testes. So this is a revised classification of histiocytosis and neoplasms of the macrophage dendritic cell lineages. I've taken this from American Society of Hematology. This was published in 2016. So there are different groups. That is, L group is the Langerhans cell histiocytosis, which under which comes the Langerhans cell histiocytosis, indeterminate cell histiocytosis, Erdheim-Chester disease. There can be even a combination of LCH and Erdheim-Chester disease. Next is the C group, that is the cutaneous non-Langerhans cell histiocytosis. Next comes the R group, that is the Rosai-Dorfman disease. This includes familial Rosai-Dorfman disease and sporadic Rosai-Dorfman disease, which further has classical RDD, extranodal RDD, RDD associated with neoplasia or immune diseases, and the unclassified type. Then comes the M group, that is malignant histiocytosis, and comes the H group, that is hemophagocytic lymphohistiocytosis. So let us see the R group. So in the R groups comes the familial RDD, that is Faisalabad or the H syndrome, and the FAST deficiency, which is FAST or the autoimmune lymphoproliferative syndrome related RDD. Then comes the classic or the nodal RDD, and our case fits into this extranodal RDD, which may affect the bone or the CNS. Now, CNS may be with or without IgG4 syndrome association. Then comes the RDD with associated with neoplasia. That could be post leukemia, post lymphoma, and next comes is the immune associated, that is those related to SLE or idiopathic juvenile arthritis, autoimmune hemolytic anemias, or HIV associated. So we will have a look at the RDD of the CNS. So by definition, RDD of the CNS or the meninges with or without systemic lesions pathologically corresponds to its counterparts occurring elsewhere. It is a clonal histiocytic proliferation characterized by large S100 positive histiocytes with variable emporipolysis. Now, this is the WHO CNS 5 2021 localization. Isolated intracranial involvement is rare, and less than 150 cases have been reported till date. Isolated intraventricular involvement is even much rarer. Now, RDD is present as solitary or multiple dural masses mimicking meningioma. These may affect the cerebral convexity, cranial base, and or cavernous sinuses. Now, RDDs on imaging can be differentiated from meningiomas as these are T2 hypointense, whereas the meningiomas are T2 hyperintense. Two locally aggressive cases uh, have been reported by Toe et al., which were also invading the dural sinuses. So, RDD may present as pachymeningitis. The parenchymal lesions may mimic lymphomas, and even parasagittal, suprasellar, and petroclival region may be affected. Isolated intraventricular location is rare. In lateral ventricles, only two cases have been reported, that is by Friconet et al. And Patwardhan et al. And in the fourth ventricle, which is also extremely rare, the first case was reported by Morandi et al. And ours being the second case in the literature. So males are commonly affected, and the median age for CNS is 40 years. Clinical features, they may be systemic or isolated cranial involvement. The patients with CNS involvement may present as raised ICT or focal neurological deficits. The patients with cellular lesion may present as hypopituitarism, diabetes insipidus. The patients with classical systemic signs, they show painless lymphadenopathy, fever, weight loss. However, only 30% of cases show these typical classic signs and 52% show no systemic disease. So emporipolysis is a typical finding, but may be inconspicuous or absent and is not pathognomonic of RDD. It may be found in various neoplastic and non-neoplastic lesions. Neoplastic lesions such as T-cell lymphoma, B-cell lymphomas, multiple myeloma, breast carcinomas, and leukemias. And the non-neoplastic lesions such as RDD, Erdheim-Chester disease, autoimmune hemolytic anemia, myelosclerosis, ITPs, oligodendrocytes in multiple sclerosis, cerebral infarcts, Creutzfeldt-Jakob disease, and physiologically it is noted in the megakaryocytes of the fetal liver. Histiocytic markers are positive due to cytoplasmic neutral fat. CD11C, CD68, CD163, and S100 positivity is noted. CD1A and CD207, that is Langerhans, is negative, and this rules out Langerhans cell histiocytosis. Cyclin D1 positivity in cases suggests possibility of MAP activation pathway. p-ERK is a highly specific nuclear and a cytoplasmic stain for MAPK pathway, and BRAF V600E is positive in 12.5% of cases, which has a therapeutic implication. Coming to electron microscopy, ultrastructurally extensive pseudopodia and lack of Burbeck granules, viral particles, and other evidence of infection is consistently lacking in RDB. Coming to diagnostic molecular pathology, the genetic mutations are BRAF V600E, which is positive, which is found in 12.5% of cases, can be studied by digital PCR. The KRAS is positive in 25% of cases, NRAS in 12.5, and MAP2K1. So this can be done by targeted DNA RNA sequencing and whole exome sequencing. Coming to diagnostic criteria for Rosai-Dorfman disease as per WHO CNS 5 2021, essential criteria: a population of large histiocytes with round nuclei, vesicular chromatin, distinct nucleoli, and abundant pale cytoplasm, and negativity for Langerhans cell markers, that is CD1A or CD207, that is Langerhans, and positivity for S100. Now, these are the desirable criteria. Prognosis and treatment of RDD. Overall, the prognosis is favorable. Resected lesions undergo surgery, and non-resectable lesions are treated with steroids, radiotherapy, and MAPK signaling pathway inhibitors. Now, these are the differential diagnosis of lymphohistiocytic diseases in the CNS. So coming to Langerhans cell histiocytosis, this commonly affects the craniofacial bone, skull bone, and these appear as lytic lesions. They may affect the meninges as well. And microscopically, we see the Langerhans cell, which is a histiocyte with reniform or kidney-shaped or convoluted nuclei with nuclear grooves and foamy cytoplasm. Now, eosinophils are commonly found in these lesions. You can see abundant eosinophils, and emporipolysis is absent. So, IHC is positive for CD1A and CD207, and BRAF is positive in 50 to 60% of cases. And Ki67 index may be variable, may go even up to 50%. So, treatment is chemotherapeutic drugs and MAPK pathway inhibitors. Coming to Erdheim-Chester's disease, this commonly affects the male, the elderly male, median age is 50 years, affects cerebrum, dura, and microscopy reveals foamy to epithelioid histiocytes with some Teuton giant cells, and peripheral part of the tissue shows pyloid gliosis. These are again positive for the histiocytic markers along with factor 8A. S100 expression is variable and CD1A is negative. Now again, BRAF is positive in 50% of cases. And the treatment is surgery, cladribine, BRAF and MEK inhibitor drugs. Coming to juvenile xanthoplanelloma, it commonly affects the children and the young adults, and in 5% of cases, it may be associated with the cutaneous lesions. So in the CNS, it affects the brain, the intradural extramedullary spine, the nerve roots, and the meninges. Microscopically, it overlaps with the Erdheim-Chester disease, and there are rounded to spindle histiocytes with vacuolated cytoplasm and scattered Teuton giant cells. Now, how do these look? There is a ring of nuclei which surrounds the eosinophilic cytoplasm, and the peripheral part shows the foamy cytoplasm. And there are some scattered foreign body giant cells, lymphocytes, and occasionally eosinophils may be found. Again, these are positive for histiocytic markers, factor 8A. The LCH markers are consistently negative, and BRAF may or may not be positive. Last and the very rare is histiocytic sarcoma. It may affect any site of the CNS and the meninges. Now, the histiocytic sarcoma shows all the features of malignancy. It's a highly cellular lesion composed of non-cohesive infiltrates of large histiocytes. They show prominent nucleoli. There is increased mitotic activity, nuclear pleomorphism. Again, histiocytic markers are positive and CD34 expression is variable. And the prognosis is grim. It is less than 12 months. So this is a rare case, rare and unusual presentation of the Rosai-Dorfman disease of the fourth ventricle, which mimics intraventricular tumors commonly occurring at that age group, that is medulloblastoma or ependymoma. However, the treatment of choice remains the same, total surgical excision, and this RDD has a favorable prognosis when the lesion is completely resectable. Thank you very much.